Welcome to the deep dive. Today we're tackling a really common scenario we all face in small animal practice. Abdominal enlargement. It's one of those presentations that walks in the door all the time, and it's, as we know, it can signal anything from something pretty manageable to a real emergency.
That's absolutely right. And for us as veterinary clinicians, having a really solid, structured way to think through abdominal enlargement is, well, it's absolutely key to figuring out what's going on and how we can best help our patients.
Exactly. So that's our mission today,
Yeah.
to give you that clear framework for assessing this finding. We've sifted through the essential info, distilled the core concepts, and we're going to unpack it in a way that's hopefully quick but thorough.
Yeah.
Think of this as your go-to for getting a handle on that distended abdomen.
And let's be honest, clinical practice is busy. It's a whirlwind. So our goal here is to make this information really accessible and, efficient a chance to refresh your knowledge and maybe even sharpen your understanding of this critical area.
Okay, let's dive in then. The absolute first thing we need to do when we see that enlarged abdomen is, well, define the problem, right?
Right.
It's so easy to jump to the conclusion of fluid, but we've got to remember there are other possibilities. Is it liquid, is it solid, or is it maybe air causing that distension?
That's a crucial initial thought. Yeah, it could be gas, it could be a mass or organomegaly, something solid taking up space, or even just a loss of abdominal muscle tone giving that appearance, sometimes without a huge increase in internal contents.
Right, and that's where the classic 5Fs mnemonic can be a really useful starting point, just to get our brains going.
Good old 5Fs.
We're talking fluid, fat, flatus, and, think about a bloating Great Dane with GDV as a prime example of flatus causing major
Oh,
dissension.
yeah, dramatic.
Then feces, like constipation or impaction. Finally, feces, pregnancy.
And beyond that handy mnemonic, we also need to keep in mind just straightforward enlargement of specific organs, like a massively enlarged spleen or liver, or the presence of any kind of intra-abdominal mass or tumor.
Well, of course.
All of these will obviously contribute to increased abdominal size.
And it's interesting how in dogs with hyperadrenocorticism, Cushing's, we see that characteristic pot-bellied look.
Yeah, the classic pot belly.
And it's often not just one thing, is it? It's usually a combination of factors.
Exactly. You've got weakened abdominal muscles, then there's a redistribution of fat into the abdomen, and often an enlarged liver, hepatomegaly. It's multifactorial for that specific condition.
Okay. And another really important point you mentioned earlier is differentiating abdominal effusion from pleural effusion.
Yes, very important distinction. While both involve fluid where it shouldn't be, abdominal effusion itself rarely disrupts organ function directly in the same immediate, life-threatening way that the respiratory compromise we see with pleural effusion does.
That's such a key distinction, especially when we're triaging patients, right?
Yeah.
Fluid compressing the lungs is a much more immediate threat than fluid just kind of sitting in the abdomen.
Correct. So once we have that broad definition, is it fluid, fat, flatus, etc., often our next step as clinicians will involve, diagnostics like imaging, maybe ultrasound or abdominocentesis to really pinpoint what's going on underneath.
Right. And if we confirm that fluid is indeed the cause of the enlargement, then we need to refine the problem further.
Absolutely. If we've got intra-abdominal fluid, then characterizing that fluid becomes absolutely crucial for guiding our next diagnostic steps.
It's tempting to see a big fluidy belly, think ascites, and maybe even lean towards certain treatments based on that assumption.
Oh, definitely happens all the time.
But we really need to dig into what that fluid is telling us first.
You're spot on. Just assuming it's ascites without any further investigation can really send us down the wrong path sometimes. The good news, though, is that the tools we have at our disposal to classify these fluids are generally quite straightforward.
Yeah, they're usually readily available in most clinics. We're talking about those simple but powerful initial steps. A good look at the gross appearance of the fluid. What color is it? Is it clear, cloudy, bloody?
Then measuring its specific gravity and protein concentration using a refractometer workhorses in any practice.
Totally. And then, of course, examining a stained smear under the microscope.
Yeah, cytology.
Which can often give us immediate insights or at least guide us on whether we need to send it out for more specialized analysis, like culture.
And based on these relatively simple tests, we can start to categorize the abdominal fluid, which immediately helps us narrow down our differential list.
Okay, so what are the main categories we're looking at?
Well, we might see hemorrhagic fluid, actual blood.
Right, which should immediately make us think about a source of bleeding somewhere in the abdomen.
Exactly. Or we could encounter what looks like urine, especially in those cases where we suspect maybe a bladder rupture or ureteral tear.
Okay, Then we get into the categories of transudates, modified transudates, and exudates. And these really start to paint a picture of the underlying pathophysiology, don't they?
They really do. A pure transudate is generally pretty quiet cellularly. Mostly you're seeing those mononuclear cells.
Right. Low protein, low specific gravity.
Yeah, low protein levels, typically under about 25, maybe 30 grams per liter, and a low specific gravity, usually below 1.018. Think of it as a pretty passive leakage of fluid, low in cells and protein.
Okay. And a modified transudate.
As the name implies, it's sort of a step up from that. We see a bit more cellular activity, often with some neutrophils starting to show up.
Oh, okay.
The protein levels are a little higher, maybe up to 35 grams per liter, and the specific gravity is in that middle range, say 1.018 to 1.025.
Might look a bit different grossly, too.
It might. It could even have a slightly pink or blood-tinged appearance, serosanguinous.
Huh.
But importantly for us as clinicians, the underlying causes are generally the same as for a pure transudate.
Oh, right.
It's just, maybe it's been in the abdominal cavity a bit longer, allowing for more protein and cells to accumulate, or there's slightly higher pressure involved.
Gotcha. Then we have exudates, which is where the inflammation really kicks in.
Yeah, exudates are where the inflammatory cells really party, as you said. These generally indicate a more significant inflammatory or infectious process. We typically see a high cell count,
How high?
usually over 5.0 by 109 cells per liter. But it's important to remember there are exceptions, like with FIP or some neoplastic effusions, which can actually have a more moderate cellularity sometimes.
Okay, that's a good point. And what kind of cells are we seeing?
Right. The predominant cell type in an exudate is usually neutrophils, often along with mononuclear cells like macrophages. And then we further differentiate these for our clinical decision-making.
Into septic and non-septic.
Exactly. If we see nasty-looking degenerate neutrophils, swollen, maybe lateralized, and evidence of bacteria, maybe even intracellular bacteria.
And that's a septic exudate.
That's septic, and
Wow.
we know we're dealing with an infection, peritonitis.
And if the neutrophils look healthier, non-degenerate, but there's still a lot of cellular activity.
That points towards a non-septic inflammatory cause. The protein content in exudates is typically high, above 30 grams per liter, and the specific gravity is usually greater than 1.025.
Okay. We also need to consider eosinophilic effusions.
Right. Less common but important. They have characteristics of either a transudate or an exudate, but the key feature is a significant number of eosinophils.
How many are we talking?
Usually more than 10% of the total nucleated cell count. Finding those should prompt us to think about specific underlying issues.
Like parasites or allergies.
Or mast cell tumors, yeah, things like that.
And then there's chyle, which is a really distinctive one, isn't it?
Oh yeah, chyle's usually quite obvious. This triglyceride-rich fluid has that classic milky, opaque appearance that doesn't clear even after you spin it down in the centrifuge.
Right, it stays milky.
Exactly. The protein levels can vary quite a bit, maybe 20 to 60 grams per liter, and the specific gravity is usually above 1.018.
Is there a way to confirm it's chyle?
Yes. A key diagnostic trick here is that it will clear when you add ether, which dissolves those fats. Also, if you can run the tests, the triglyceride concentration in the fluid will be much higher than in the serum.
Ah, okay.
While cholesterol will be lower, giving us that cholesterol to triglyceride ratio of less than 1. And under the microscope, you might also see those pseudinophilic fat globules.
It's worth a quick mention of pseudoclus effusion as well, I suppose.
Yeah, it can sometimes visually resemble chyle, look milky, but it won't have those same chemical characteristics, particularly the high triglycerides. It's usually from cell breakdown in chronic effusions.
But clinically, does distinguishing them really change our initial approach much?
Often not dramatically, no. The practical relevance of definitively distinguishing between the two in terms of significantly altering our initial search for the underlying cause is often questionable in day-to-day practice.
Okay. Now, shifting gears slightly, beyond just classifying the type of fluid, where that fluid is located can give us even more valuable clinical information, can't it?
Absolutely. Distribution matters. For instance, the presence of both abdominal and pleural effusion often suggests a more widespread systemic disease process affecting multiple body cavities.
Right. So if you find fluid in both the chest and the belly, you're thinking about things like heart failure.
Exactly, particularly right-sided heart failure, or significant hyperproteinemia, systemic coagulopathies causing bleeding everywhere, or feline infectious peritonitis, FIP. Those are all examples of conditions that can manifest with fluid in both places.
Okay. On the other hand, if the fluid is confined to just the abdominal cavity.
Well, it could certainly still be due to one of those generalized issues we just mentioned, but it can also point us towards a more localized problem within the abdomen itself.
Makes sense.
And another clue. If you happen to see subcutaneous edema, like swollen legs or ventral edema, in addition to abdominal effusion,
Hmm.
that should really raise your suspicion for a significant drop in plasma protein levels, like severe hyperproteinemia. The low oncotic pressure is affecting tissues everywhere.
Got it. So let's circle back to those transudates and modified transudates. When we've classified the fluid like that, we often use the specific term ascites.
Yes, that's generally how ascites is defined: abnormal accumulation of transudate or modified transudate.
And what's the most common underlying driver for that?
By far, the most common underlying driver of ascites is an increase in pressure within the portal venous system, which we call portal hypertension.
Right. Increased pressure in the vein draining the gut and spleen.
Exactly. And for us to really understand what's going on, it's helpful to categorize portal hypertension based on where that blockage or restriction to blood flow is occurring within the portal system.
Okay. How do we break that down?
We generally talk about prehepatic, intrahepatic, which can be further divided, but let's keep it broad, and posthepatic obstruction.
Okay, let's start with prehepatic hypertension.
Right. This is actually a less common cause of significant ascites in our small animal patients, surprisingly.
Oh, really? Why is that?
Well, if the portal vein itself gets blocked before the liver, the body has some clever ways to try and compensate. It can increase lymphatic drainage from the intestines and, importantly, develop collateral blood vessels, shunts basically, to bypass the obstruction.
Ah, so the pressure doesn't build up quite as much.
Potentially, yes. Causes here might include a narrowing or stenosis of the portal vein itself, a blood clot or thrombosis within the vein, or maybe external compression, perhaps from an abscess, a tumor, or enlarged lymph nodes right near the liver in the porta hepatis.
And what would we expect to see clinically?
Typically, with prehepatic hypertension, the liver size itself will be relatively normal, maybe even small if it's chronic, and the ascites fluid tends to have a low protein content, usually less than 25 grams per liter.
Okay. What about intrahepatic portal hypertension within the liver itself?
Right. This can arise from a variety of conditions directly affecting the liver tissue. We might see it with things like hepatic arteriovenous fistulas.
Abnormal vessel connections.
Exactly, which can increase blood flow and pressure within the portal system. More commonly, chronic active hepatitis, liver cirrhosis and fibrosis, some types of intrahepatic neoplasia, and even severe fatty infiltration, like hepatic lipidosis in cats, can all contribute.
And how does that present? Liver size, fluid.
It's more variable. With intrahepatic portal hypertension, the size of the liver can be quite variable. It might be normal, enlarged, or even smaller and nodular in cirrhosis. And the protein content of the ascites fluid can also vary within a broader range compared to prehepatic.
Right. Now, posthepatic obstruction after the liver, you said this is the most common.
Yes, this is actually the most common type of portal hypertension we encounter in practice leading to ascites.
Okay. What causes that?
This is usually caused by problems affecting blood flow out of the liver via the hepatic veins or the caudal vena cava. So things like right-sided heart failure are a big one. Also, pericardial diseases that restrict diastolic filling, like pericardial effusion or constrictive pericarditis. Sometimes right atrial neoplasms obstructing venous return, or any kind of obstruction like a thrombosis or external compression from a tumor affecting the caudal vena cava or the hepatic veins themselves.
And what's distinct about this type?
What's really informative here is that because the pressure in the caudal vena cava is elevated at the same time as the portal vein pressure, there isn't that same pressure gradient that would drive the formation of those collateral vessels we saw with prehepatic obstruction.
Ah, okay. So no bypass routes develop.
Generally, no. As a result, the acidic fluid in these cases tends to have a relatively high protein content, often above 25 grams per liter, and it frequently approximates the serum albumin concentration because it's largely derived from protein-rich hepatic lymph weeping from the liver surface.
Interesting. And liver size. Other signs.
We also typically see an enlarged, congested liver on examination or imaging, and quite often these patients will have both ascites and pleural effusion concurrently, which is less common with the other types of portal hypertension that tend to cause more isolated ascites.
That's a really useful clinical distinction. Let's also touch on hyperproteinemia as a potential cause of abdominal enlargement, specifically low albumin.
Right. It's a common thought, isn't it? That low protein in the blood just leaks out and causes ascites.
Yeah, the old Starling's forces idea.
Exactly. But it's actually quite rare for hypoproteinemia to be the sole cause of ascites in dogs and cats.
Why is that?
Well, the blood vessels within the liver, the sinusoids, are normally quite permeable even to larger protein molecules like albumin.
So they leak protein anyway.
To some extent, yes. Unlike the tight capillaries we see in muscle or skin, the oncotic pressure gradient across the liver sinusoids is normally quite low. So just having low albumin in the bloodstream doesn't have a huge direct impact on fluid exchange across those specific vessels.
So that older teaching that decreased oncotic pressure is the main driver of ascites formation in hyperproteinemia isn't really the full picture.
Not entirely, no. What's actually more significant in cases of hypoproteinemia due to either, say, liver disease causing poor production or protein-losing kidney disease is that these conditions often trigger the body, through complex mechanisms, to retain sodium and water really avidly.
Yeah, okay. How does that happen?
It involves things like activation of the renin-angiotensin-aldosterone system, RAAS, maybe altered levels of atrial natriuretic peptide, changes in kidney blood flow.
Yeah.
It's complicated, but the end result is sodium and water retention.
And that retained fluid contributes to the ascites.
Exactly. That's really a key player in driving fluid retention and ascites formation. And specifically in liver cirrhosis, you also have that physical obstruction to blood flow out of the liver, the postsinusoidal component, contributing to the increased portal pressure as well.
So how low does albumin typically need to be for hypoproteinemia alone to cause ascites?
Generally, ascites that is purely due to low creatine levels doesn't usually occur unless the albumin concentration is remarkably low. We're talking typically below 15 grams per liter and often even less than 10.
Wow, that's really low.
It is. So here's a clinical tip. If you have an animal with low albumin, say 18 GL, but they have ascites, it's much more likely that underlying liver disease or maybe glomerular disease with that associated sodium retention is the primary driver, rather than just simple protein loss from the gut, like a protein-losing enteropathy, which would typically need much lower albumin to cause ascites on its own.
That's a very helpful point. We should also briefly consider lymphatic obstruction.
Yes, definitely. Obstruction of lymphatic flow within the abdomen can also lead to the accumulation of fluid, resulting in ascites.
How might that happen?
It could happen due to physical blockage of the major lymphatics or the thoracic duct, maybe by neoplastic masses infiltrating them, or sometimes due to disruption of normal lymphatic drainage, maybe associated with something like a diaphragmatic hernia.
Now, let's turn our attention back to exudates. You mentioned septic and non-septic. What causes non-septic exudates?
Right. Non-septic exudates can arise from a variety of inflammatory conditions within the abdomen that aren't primarily bacterial infections. Bile peritonitis is one important example.
Ah, spilled bile.
Exactly. And it's interesting to note that it often starts as a chemical non-septic peritonitis, but it can quickly progress to a septic peritonitis if there's bowel contamination or tissue necrosis.
And you'd expect jaundice in those cases.
Often, yes, clinical signs of jaundice will be present. Feline infectious peritonitis, FIP, is another well-known cause of a typically non-septic exudate in cats.
Right, the high-protein, sometimes sticky fluid.
Exactly. Often has those viscous fibrin strands, although, as we mentioned, the cellularity can be quite variable, sometimes lower than you'd expect for an exudate.
What else?
Neoplasia itself, particularly carcinomas seeding the peritoneum, can trigger a non-septic exudative effusion, as can other causes of non-septic peritonitis, for example, secondary to severe pancreatitis. Chronic inflammatory liver diseases, sometimes complications from diaphragmatic hernias, certain types of fat inflammation like steatitis, and even urine peritonitis can sometimes present as a non-septic exudate initially.
Okay, and then the septic exudates.
Septic exudates, as we discussed earlier, are characterized by that high number of degenerate neutrophils and, crucially, the presence of identifiable bacteria within the fluid, maybe intracellularly.
And the causes are usually pretty serious.
Yes, these are typically seen in cases of frank bacterial peritonitis resulting from things like a penetrating abdominal wound, a rupture or perforation of a hollow viscus like the bowel or stomach.
Leaking gut contents.
Precisely. Or sometimes as a later, more severe stage of bile peritonitis if it gets contaminated.
Got it. What about those eosinophilic effusions you mentioned? What causes them?
Eosinophilic effusions, defined by that high percentage of eosinophils, can be associated with a few specific things. Aberrant larval migrations of parasites like heartworm, maybe? Mast cell tumors that have degranulated within the abdomen can release factors that attract eosinophils. Certain types of lymphoma, some fungal diseases, and the less common systemic condition called disseminated eosinophilic granulomatosis.
Right, so finding lots of eosinophils points you down a different diagnostic path.
It definitely broadens the differentials in a specific way.
Okay, let's talk about hemorrhagic effusions or hemoabdomen. What does the fluid look like initially?
Well, initially, if you tap it right after the bleed starts, the cellular makeup will look very similar to peripheral blood, mostly red blood cells, normal-looking white cells in normal proportions.
But does that change over time?
Yes. As time goes on within the abdominal cavity, we'll typically see an increase in the number of neutrophils and especially macrophages responding to the blood.
Ah, the cleanup crew arrives.
Exactly.
Yeah.
And the presence of erythrophagocytosis, seeing those macrophages actively engulfing red blood cells under the microscope, can be a helpful feature.
Why is that helpful?
It helps distinguish a true hemorrhagic effusion from just accidentally hitting a small blood vessel during your abdominocentesis, a blood tap. You won't see erythrophagocytosis in a fresh blood sample.
Good tip. Any other clinical signs associated with hemoabdomen?
It's worth remembering that animals with a slow, chronic bleed, perhaps from a bleeding tumor in the spleen like a hemangiosarcoma, might present with non-specific signs like increased thirst and urination, polydipsia, polyuria.
Oh, interesting. Why?
The mechanism isn't fully clear, maybe related to chronic anemia or tumor factors, but their urine-specific gravity can be quite variable in these cases, so don't rule out a hemoabdomen just because the USG isn't concentrated.
Okay. And the causes. Tumors are a big one, right?
Definitely. Bleeding intra-abdominal neoplasms, especially splenic hemangiosarcoma in dogs, are very common causes, but also trauma leading to laceration or fracture of organs like the liver or spleen. Avulsion of renal arteries, again, often traumatic, or it can even be iatrogenic, occurring as an unfortunate complication after a surgical procedure like a spay.
And systemic issues.
Yes, systemic bleeding disorders, or coagulopathies like rodenticide toxicity or immune-mediated thrombocytopenia, can also result in hemorrhagic effusions, often in multiple body cavities.
You mentioned checking if the fluid clots. Why is that important?
Yes, that's a really practical tip. After collecting a hemorrhagic effusion, always check if it clots in a plain tube. If the blood doesn't clot, and assuming the animal doesn't have a known underlying coagulopathy, it strongly suggests it's been within the abdominal cavity long enough for the body's natural processes to break down the fibrinogen, essentially defibrinating it. Fresh blood from a vessel tap will clot readily.
That's very useful. Finally, a quick word on urine as a cause of abdominal enlargement. Uroabdomen.
Right. If you suspect the distension might be due to urine, perhaps from a severely overfull bladder, or more likely, a ruptured bladder or ureter.
And you collect fluid.
And you collect fluid, maybe it looks quite watery, and you're unsure if it's indeed urine or just a very dilute effusion, say a transudate.
What can you do?
Measuring the urea or creatinine concentration of the fluid and comparing it to the patient's plasma levels can be very helpful.
How so?
In cases of urine leakage into the abdomen, these waste product levels, especially creatinine, which is a larger molecule, and equilibrate slower, will be significantly higher in the abdominal fluid compared to the levels in the patient's plasma or serum, usually at least twice as high for creatinine.
Okay. Is there a time limit on that test being useful?
Yes, that's an important caveat. This comparison is most diagnostically useful within the first 24 hours or so after the suspected rupture. After that time, the urea and creatinine levels tend to equilibrate between the abdominal fluid and the bloodstream.
Ah, they balance out.
Exactly, which can reduce the diagnostic value of just comparing the fluid to the blood. It might still be higher, but less dramatically so.
Good to know. So as we bring this all together, the absolute fundamental first step when we're faced with a patient with abdominal enlargement is to really, really nail down what is causing that enlargement. Is it fluid, fat, flatus?
Absolutely critical first step.
And if it turns out to be fluid, then taking the time to thoroughly characterize that fluid through those relatively simple in-house tests like appearance, SG, protein, and a quick smear exam is truly invaluable.
It really is. It allows us to build a much more focused and logical list of potential underlying causes, our differential diagnoses.
But it's also crucial for us to remember as clinicians that there can definitely be overlaps, can't there?
Oh, absolutely. There can be overlaps in the differential diagnoses we consider for different types of fusions, and the clinical presentation in our patients isn't always going to fit neatly into those perfect textbook descriptions. Life's messy.
So true. That's why it's so vital to integrate all the information we gather in our assessment of the patient.
Everything matters.
Their history, the findings on our physical examination, the results of our fluid analysis, any other laboratory tests we run, blood work, urinalysis, and of course, any diagnostic imaging we perform, like x-rays or ultrasound.
hmm It's all pieces of the puzzle that we need to put together, synthesize that information to arrive at an accurate and timely diagnosis for our patients.
Couldn't agree more. A systematic and thoughtful approach is really the key to navigating these sometimes quite challenging cases effectively and providing the best possible care.
Definitely.
So, to wrap up this deep dive specifically aimed at you, our fellow veterinary clinicians, the key takeaway really is that a structured approach to any small animal patient presenting with abdominal enlargement is absolutely essential. Don't just guess.
Have a plan.
And when fluid is involved, the thorough characterization of that fluid, looking at its gross appearance, protein, and specific gravity, and crucially, the cytology provides a critical foundation for making informed diagnostic and treatment decisions in our daily practice.
This knowledge really provides a practical and hopefully efficient framework for navigating what can sometimes be a complex and concerning clinical presentation in our patients.
And on that note, here's a final thought for you to consider in your own busy practice. Given the often subtle and diverse underlying causes of seemingly straightforward cases of abdominal enlargement, how consistently are you incorporating fluid analysis into your diagnostic protocols?
Good question.
And, perhaps more importantly, what impact might a more routine, more consistent use of these simple, often quick tests have on the accuracy of your diagnoses and ultimately the outcomes for your patients? It's definitely something valuable to reflect on in our ongoing efforts to provide the best care possible.
Food for thought indeed.
Thanks for joining us for this deep dive.